plasmapheresis of IVIG is also sepsis. An outside indication of plasmapheresis is sepsis. You understand what I'm saying? That's why an outside indication is even dengue. You understand? Outside indication because of this FC fraction that is there. Whereas the FAB fraction is to prevent further autoantibodies from joining. Just remember these two things, FC and FAB. That's all. Okay?
Sir, if FAB fraction prevent binding of autoantibody. So
it saturates the receptor sites.
So if I consider GPS case mein there is development of autoantibody. If FAB fraction already saturated with IV means antibodies, so autoantibody
will not bind.
Will bind to the FC portion then?
No, autoantibody. There are two things that are happening. One is the FC portion is taking up the autoantibodies and finishing it off. Okay. And the other is a FAB fraction preventing the autoantibodies getting to the receptors. Antibodies have to also act on the receptors, right? The NN junction. It's not reaching them because the FAB fraction is saturating the receptors, not allowing the autoantibodies to go. So you understand. So the body itself has got its mechanism of opsonization and phagocytosis at that time. Okay. That's good.
Then they also at low doses they help activate the complement cascade also with specific interaction with pathogens. So this is a function that reverses in high doses to complement inactivation by specific interactions.
So now you understand why an antibody works, right? An antibody is working against an autoantibody. Okay.
So basically, when you give high dose IVIG, it leads to an inhibitory effect. So the monomeric IgG in high dose IVIG causes blockade of your FC fragments by saturating them on immune cells, and they attenuate the immune complex mediated inflammation and autoimmunity. So this causes increase in platelet counts also on ITP. So that's why for autoimmune you give a high dose of IVIG. Then IVIG modulation for cellular immunity is also there, which inhibits the activation of monocytes and macrophages. Induction of anti-inflammatory cytokines from innate cells and leads to decreased macrophage responsiveness to interferon. Then there's inhibition of the maturation and differentiation of your cells also. Then IVIG is cytotoxic to neutrophils and eosinophils, so it leads to a switch from pro to an anti-inflammatory environment in the patient. Then it can also induce apoptosis by inducing the FAS apoptotic pathway. So this in particular T helper cells. Then it enhances the immunosuppressive effects also through the T cell population, and it exerts an immunosuppressive action by suppressing the proliferation of B lymphocytes, which causes the modulation of antibody production. It also modulates the activity of endothelial cell proliferation and expression of adhesion molecules in vascular lumen, which leads to anti-inflammatory disorder like symptoms in vasculitic disorders. So next I'll discuss the indications. So the main thing that we look at is GPS and myasthenia, but there are many other indications for IVIG. So basically in GPS and myasthenia, these are GPS, it is an alternate first line treatment, only comes under category 1. This doesn't have categories, but that way. So here there's consistent evidence of well-performed randomized controlled trials. And in myasthenia gravis, it's used for short-term management of acute exacerbations in myasthenia gravis. So this also has evidence from randomized controlled trials. So the treatment for both of these is 2000 mg per kg, which is given divided and given within 2 to 5 consecutive days.
Different from plasmapheresis, where this goes over quickly.
So here you give around 400 mg per day.
So you have to remember in grams because it comes in grams. So you always remember as in grams. So 0.4 grams a kilogram is the total. Is you have to give to totally reach 2 grams a kilogram. You understand? No? So 0.4 gram a kilogram. So in 5 doses you reach 2 grams. The ultimate is 2 grams you have to give total. Okay, that's for 0.4 gram a kilogram. Okay? So 5 consecutive days, and 2 to 5 consecutive days you should give it and see what is happening. Okay.
These are some other indications, also primary, secondary. So primary is also there in multiple neuropathy. There is multiple myeloma, hemolytic disease of newborn. Then secondary has autoimmune cutaneous blistering diseases. So the stoma.
See, organ, solid organ transplantation related issues in multiple myeloma disease.
And in secondary there is myasthenia gravis, ambulatory multiple sclerosis, inflammatory myopathies, then polyneuropathy, intractable epilepsy, cardiomyopathy, pure cell aplasia, hemolytic anemia, and refractory.
So that's why there is also role in critical illness polyneuropathy myopathy. Because we also don't know the pathogenesis there, it might be related to things. We may also try it out, but it's not the road. Okay.
So this is also indications that the dose strategy. So there are basically different types in the way that you dose it. So you have a low dose replacement therapy, there's a high dose immunomodulatory therapy, and there's a post exposure prophylaxis or hyperimmune type of therapy that is also given. So in your primary and secondary humoral immunodeficiency, so this is all your Dosage syndrome.
We will not be in contact with any of these things. We will be only in contact with the high dose ITP, high dose ITP. That is all that we'll be in contact with. Okay. Yeah.
Even post exposure to any of these diseases, so hepatitis A, tetanus, rabies, diphtheria, you give a post exposure prophylaxis of IVIG. So this we discussed. So these are immunoglobulins are basically glycoprotein molecules which are produced by your plasma cells. So they have again the same arm that we discussed as an adaptive arm, which is so it also contains your natural immunoglobulins, which is IgG, IgM, IgA. So and IgE, all these various classes are there, but the main is your IgG and the others are present in smaller percentages. So it can be subdivided into all of this. The plasma concentration of IgG, which is the most, is around 7 to 1600 mg per dl, which is 75 to 80% of the immunoglobulins. IgA is the second most, which is only about 15%. And IVIG is basically a constituent of pooled immunoglobulins, which are derived from around 1000 to 10,000 healthy donors, depending on the manufacturer. So it just plays a role in the adaptive immunity, and this we discussed in detail. Then administration. So IVIG can be given either as a 5%, which is 50 mg per dl, or 10%, which is 100 mg per dl, liquid or a lyophilized preparation. So it's administered intravenously, and the half-life is about 3 to 4 weeks. So low dose is what we had discussed for all those autoimmune conditions, which is not very important in our scenario. So I'll discuss more about high dose immunotherapy, immunomodulatory and anti-inflammatory therapy. So this is ranging from 1000 to 3000 mg per kg of body weight to achieve a peak plasma concentration of 2500 to 3000 mg per dl. So the dosage frequency, everything is dependent on the patient, the adverse effects, how much dose you want to give to that patient based on his clinical condition. So it can be a high dose protocol, but sometimes the initial dose, a maintenance dose, or an infusion is given to the patient. So your protocol is 2 mg per kg.
No, 2 grams, no, that is, because it's 400 milligram per day for 5 days. So 2
or 2 grams per kg course divides into 400 mg per kg over 5 days is how we give. So this is just the peak concentrations, the frequency of dosing, and the desired drug levels that we want. So for us, again, we are looking only at high dose immunomodulation therapy. So your concentrations you want is 2500 to 3500, and you divide it over a period of few days, usually 5 days. So then next is another hyperimmune therapy, which is given as a single intramuscular dose after suspected exposure to any particular pathogen. So in addition to an intramuscular route, some of these immunes are given as IVIG therapy also. So they are administered in a multi-dose regimen, which is 750 mg per kg of RSV. IVIG is given every month in RSV. It's basically in response to any specific virus exposure, so either hepatitis A or rabies or RSV, which is most commonly given in children. So the dose of that is given after any exposure. So it's like a post-exposure prophylaxis that is given to the patient. Then another infusion can also be given to a patient. They are started at the rate of 0.5 to 1 ml per kg per hour for the first 15 to 30 minutes. And if there is no adverse reaction, then you can increase the rate every 15 to 30 minutes to a maximum. It's very important for you
because RDMA you're giving a protein. So that's why, like any albumin, you will probably start at 50 ml or 40 ml an hour. And like albumin, you tell you start at 20 or 30 ml per hour, you watch for an hour. If there is a problem, then you increase it. Then if there's no problem, then you increase it. That's all you try IVIG also.
And maximum is 3 to 6 ml per kg per hour. And as a subcutaneous therapy is also there if there is poor venous access. So here you give at a much lower dose of 100 to 200 mg per kg, and it's given more frequently every week for 2 weeks to achieve the trough level, because a very high trough level is required for your hyperimmune. It also contains small transfusion volume of around 20 to 60 ml, so it can be given at home to patients for better compliance. So this is only given to patients who are unable to take the intravenous treatment. Then
Hello.
adverse effects.
Hello.
So adverse effects. So undesirable effects from IgIV are there in around 5 to 15% of patients on IVIG infusions and can affect 20 to 50% of all individuals who are receiving IVIG therapy. So the most common adverse effects are headache, flushing, chills, myalgia, tachycardia, lower back pain, nausea, hypotension, your normal allergic reaction. Okay, so if this happens during an infusion, the infusion should be slowed or stopped, and if these symptoms are anticipated, you can pre-medicate the patient so they can be more compliant to the therapy with intravenous hydrocortisone. Now, IVIG can also induce reactions in patients with IgA deficiency. So here they can have a severe anaphylaxis reaction soon after administration of IVIG. So this is associated with sensitization of IgA in patients with IgA deficiency. So here you can prevent it by using an IgA depleted immunoglobulin. Because anyway the percentage of IgA in your IVIG is only 15%. Then IVIG is also associated with rare cases of thrombosis. So it can cause DIC, transient serum sickness or transient neutropenia. In some cases it's also associated with causing stroke. Then it can cause life-threatening, it can be life-threatening in human parvovirus B19 infection and hepatitis C.
Stroke caused by what? I'm not getting
So it causes, it is linked with rare causes of thrombosis. So some patients, IVIG adverse effects this is.
Okay.
So in rare cases, patient can develop thrombosis, DIC, and also in very, very few document cases, stroke has occurred after IVIG treatment. And severe cutaneous vasculitis can also occur in patients who are receiving an intravenous infusion of IVIG. Again, like I said, it's associated with thrombus, so there's also rare cases of acute myocardial infarction, which is seen post-IVIG. Aseptic meningitis is also extremely rare, but it is a well-recognized complication of IVIG therapy, so the patient will have fever, neck stiffness, headache, confusion, nausea, vomiting after treatment. Then it can also result in post-infusion hyperproteinemia, increased serum viscosity, and pseudo-hyponatremia. Then complement consumption associated with like an enzymatic cutaneous reaction is also there during patients with high infusions of IVIG. And it has been linked in 2 cases of stroke, which I mentioned before. So this is not an adverse effect, this is just how it is used. So high dose IVIG treatment can neutralize or mitigate any antibody response to eliminate positive donor specific cross matches. So it permits transplantation of broadly sensitized patients and it helps treat antibody mediated reactions.
So logically it doesn't make sense because you give IVIG to plasmapheresis to the IVIG. It doesn't make sense there. Other way around, if you give plasmapheresis to IVIG, there has been proven that there was no improvement, there was no effectiveness. You understand? It was not that you gave this and this, it did well. It was not like this. So at the end of the day, we are back to at this particular moment, the current evidence goes on to say that you either do this or do that. What would I do? I would do IVIG. Why would I do IVIG, not plasmapheresis? If I would have to do it, I'd probably do IVIG. Why would I do IVIG? I don't require a hemodialysis catheter. I don't require to give heparin to the patient. I don't patients' fibrinogen and calcium levels and citrate levels and all these things are not going to take. Anything is not going to occur. Hemodynamic balance is not going to occur. I will finish my therapy in 5-6 days time. I don't need to 13 days of hospital stay, ICU stay, and all this will not occur. Give the patient go to the ward faster. Or remain in the ward easier. It can be done in the ward itself. Whereas here, if you want to do hemodialysis or plasmapheresis, patient should be brought down. GBS is the patient is just having motor weakness. Okay, otherwise he's okay, conscious, okay, come on, normal. I'll give IVIG in the morning. Why do I need to get to the ICU? Whereas when I do dialysis, I have to get the patient now. I can't do it here. I have to do it in the monitored setting. So at the end of the day, if I want to get this, I have to do IVIG. It's simpler for me. Cost-wise, it probably impacts the same because you add up ICU costs, you add up so many other costs that come into the place. Probably practically remains the same, not much of a difference. Overall picture effectiveness remains the same, which is better, equivalent. Plasmapheresis is not better than IVIG. Effectiveness wise. Effectiveness, both are equal. There is no significant benefit of IVIG over plasmapheresis. There was a study that came out. Why am I telling you this? Because there was a Lancet study that came out somewhere in I think 2000 something. One study came out where they actually compared IVIG to plasmapheresis, and they found plasmapheresis to reduce the disease progression much faster. IVIG to reduce disease progression much faster. But if you read the study properly, you realize that many of those patients, who were actually put in the arm that did not progress, did not do well, were the rapidly progressive ones. And when you say rapidly progressive, it means those that have axonal pathologies. Any patient who've got axonal pathologies in the AIDP spectrum, you have got many pathologies. So who have got the axonal pathology have got a worse prognosis. Who have got axonal pathology have got worse prognosis. So when you look at that particular trial, those patients who actually received IVIG were the ones who were rapidly progressing and the ones who basically were the axonal pathologies. So that is, plasmapheresis one was the one that were axonal pathologies. So at the end of the day, you cannot take that trial and say that IVIG is better than plasmapheresis. You understand? That's the reason that they are equivalent as of now. Even though there is a study that says almost a 30 to 40% benefit of IVIG compared to plasmapheresis, even though, because the study criteria showed that those particular patients that were enrolled were different in their symptomatologies. The more progressive or rapidly progressing they were put in the plasmapheresis group. You understand? So they obviously had longer problems. Clear? Any other queries?
So like you said, first we will do plasmapheresis, then what if can
Nothing.
we do IVIG?
Nothing you can do.
It won't have any effect.
It will not have any effect. So if the relative asks you, shall we try it, you can try it, but it's not going to have an effect. As of now, it does not have an effect. So we need more data to say that it works better. So you cannot convincingly tell the patient, oh, do you do it, it will be better. Maybe there will be ठीक हो जाएगा, because it's not possible. At the moment, there is no study that says that. At the moment, we know that one is equivalent to the second, and more is not equivalent to lesser. More is not better than lesser. Do you understand? More is not better than lesser. So you don't need to give IVIG and plasmapheresis and IVIG and it doesn't make sense. Steroids definitely doesn't work. There is no role of steroids at all. Though the pathologies, antibodies and all these things, we know steroids don't work in these cases. So in GBS there is no role of steroids. Okay? Absolutely no role of steroids.
Improvement in the patients or
General. So the entire thinking is, there is a score on the net. I don't know whether, what is it called, like EGBS or ECOG. Just open up the score, ECOG or something it's called. ECOG score in GBS. ECOG score in GBS, which has got 3 criteria. I think one is age, I think one is MRC grade or something like that. There's 3 criteria in that. And rapidity of progression or something like that is there, criteria. That actually tells you the predicted effect of this particular patient. You'll probably reduce it from there. So you first need to know what this patient is going to face. Okay, so you put it into this criteria, which is quite a well validated criteria from a Japanese study. It is recently validated also. So can you read out the criteria? Read out the criteria, someone.
0 is fully active, able to carry on all pre-disease performance without restriction. Then 1 is restricted in physically strenuous activity but ambulatory and able to carry out work of a light or sedentary nature, such as light housework, office work.
3 is anti-gravity, basically.
3 is only self-care and confined to bed or chair. 4 is completely disabled and 5 is dead.
So that is the first criteria. Second, you have age. Then second, that is the criteria, ECOG criteria. Put ECOG QXMD. Baseline. This is what it is. What we are going to see is a slow. The progression of the disease probably should be halted, and that will take. These GBS patients are going to take 4 weeks to 6 weeks to anyways to become fine, anyways to become better. A good proportion of them will remain functionally debilitated. Okay, and that will depend on the baseline status. At which time you are actually doing the the therapy or what the patient has. Okay, depending on that. So the patient may not progress only. Patient might remain with sensory or just weakness of the limbs. So you have to see what will your criteria, Niharika?
No, sir.
No. So patient that will determine whether how much you can benefit this patient. So if it's a rapidly progressive, that's what I'm trying to tell you. If it's a rapidly progressive condition, it is axonal. So if it is axonal, more often axonal.
AIDP.
AIDP, axonal motor axonal neuropathy.
Amman.
So if it is that, then the prognosis is very poor. They may not recover. 90% of them may not get a functional activity. You understand? By doing this, you are able to probably you would probably be able to reduce the duration of illness, probably prevent major issues like mechanical ventilation and long-term care.
Sir, time of onset, if patient present late with respiratory failure and all that time, at the end also we can.
You can give it, but you have gone beyond now. The IVIG, the entire process of IVIG, and this is to prevent that. Once you have gone into a situation, it will never be like that, because what happens with the GBS, centrally they are normal. Brain-wise, they are completely normal. It will never go to that situation where a patient has come in and has ventilated and come in ventilated, or come in with a intubation. No. What will happen is, more often than not, is patient will come in with a weakness of the extremity. The weakness will be progressing. Okay, you have given IVIG. During that IVIG is worsened, and then you have intubated. It will normally be like that, because you are trying to halt the progress, but it doesn't halt it. You understand? It goes on to ventilation, and then it is supportive care. You will never have it. You will never have the patient coming from home and you ventilate and you diagnose GBS. It will never occur. It will be a patient who will first present, because weakness. This is a very visible weakness. He is unable to walk is a visible weakness. So you understand it? Visible weakness. So they generally sort therapy. They take therapy, sort therapy as fast as a heart attack. Okay.